thank you for having me, Milton. It's lovely being here. So I am a surgeon. I'm the daughter of a surgeon. I am the sister of a surgeon. I am married to a surgeon. I have 2 uncles that were surgeons, all in Massachusetts for a collective century. And I have a daughter who's an aspiring actress. So there you go. So you may say we're all infected by the same virus or affected by the same delusion. But either way, I run my show. I've been a self-employed solo practitioner in general and vascular surgery, which is kind of an anomaly. I'm the last independent surgeon in my community. And I've watched healthcare disintegrate before my eyes. I have a personal stake in it. So I take it very personally. So I could decide to continue to write angry letters to the Wall Street Journal or try to change it. So I decided to do both. Which way? This way. So we've talked about this. There's no doubt our healthcare system is tragically flawed. And the truth about healthcare is because of that, this is all what's happening. You know, we have these rising deductibles. Everybody's talking about this. Medicare for all. You know, Bernie Sanders, this morning in the emergency room, but he has, federal Blue Cross. That would be great for all. Healthcare's on hold till 2020. The politicians don't have answers to this. 48% of my colleagues are burnt out. 51% are employed, which means they no longer work for you. They're working for a network or an institution, and they have a short shelf life. Price transparency is now the law. What does that mean? We keep talking about it, but is anyone really doing this? So we have to really think about all of these problems. So the patients are paying more out of pocket. We just heard this with this refill-wise. It's great that we're paying so much for our care in every step of the way, and the patients don't understand it. They come to see me, they pay their premium, and yet they're still paying a deductible. It's confusing. And these deductibles are now $1,500 to $7,500 for a family plan. That is more than what I would charge for any procedure that I do, and I'm a vascular surgeon. So what's happening here? But most people never reach the deductible. It's like Tantalus reaching for the grapes. You're never going to get to it. And $502 billion in uncompensated medical care. That's no wonder that if you go to any one of these medical conventions like Becker's Health, the entire exhibit hall is filled with revenue cycle because people are trying to get money out of patients because we can't. So how did we get here? Well, if you think about it, St. John's Infirmary in Bruges was the first hospital, the longest acting hospital in the world. It was founded about the turn of the 1000. For pilgrims and poor people, hospitals were free. Doctors attended to you in your homes, and they were erudite. The surgeons actually were kind of the worker bees who worked and had to apprentice for 7 years. Funny, it hasn't changed. I apprenticed for 7 years. We weren't considered erudite enough, though, as physicians. Then fast forward into the 1800s, we suddenly started antiseptic techniques, and suddenly healthcare became more complex and more expensive, so we needed to have to pay for that. So Blue Cross and Blue Shield was invented in the early 1920s. So this is an interesting fact, and I don't know if any of you know this, but during World War II, there was a wage freeze because Truman didn't want to have workers leaving companies that were very important for the war effort. And so they were being attracted away by increase in salaries. So he put a wage freeze into place. So instead, the companies decided to offer benefits. And one of those benefits was health benefits, and that is how we created employer-based health insurance. Then the federal programs came in. If you were too old to work or too poor and didn't have a job, they stepped in the 1960s with Medicare and Medicaid, and Harry Truman was in fact the very first Medicare patient. And then fast forward to now, we have managed care and network restrictions because the costs are so high. We have to put so many more bureaucracy on this. What's happened? Inevitably, price transparency is gone because the customer is no longer the patient, it's the employer. And the patient is further distanced from the caregiver, and I'm going to tell you the caregivers are farther distanced from the patient. And this is a problem because that is not how medical care can proceed. So we need to think it completely differently. I want everyone to think differently. I wrote this article with my other brother, who's a MPH and an electronic record specialist, IT specialist. And we thought, well, what if we thought of things differently? What if we didn't say, let's solve it from the top down, but let's think of it from the bottom up. Let's think of really where the medical economics are. Well, the intention of any medical economic is to increase access, control cost, right? With top-down solutions, great. But the reality is there's a tug of war. And why? Because no one's paying attention to technology. We don't need the fancy systems anymore. I don't treat patients the same anymore. Cancer therapy is not in a big institution where you're admitted for 2 weeks for your therapy, or even cancer therapy with an IV. It's a buccal smear and a pill that's made for you. That doesn't matter how much that pill costs, because the delivery of that pill is zero. And we are not paying attention to where healthcare is going. So navigating the hierarchy. This is the hierarchy of our medical system. So these big giant networks, and you try to navigate patients through that. We've seen tons of slides over the last couple of days, how complex this system is, how many steps to take. You can't bring patients or kind of innovation or technology through that. You're just gonna end up in a lot of false passages. But the doctor-patient relationship, the economic equation, is a peer-to-peer transaction. That's easy. That puts the direct accountability on the doctor themselves for that patient in front of them. 75% of patients consider that the relationship the top priority. We can't just erase that with no matter how much AI, although I'd love to have a robot take my call, please, I'm good with that. But this is personalized medicine. This is where we're headed. All this human genomics, this is where we're going with our healthcare. So we need a system that fits this. So where is technology taking us? Statins put me out of business as an arterial vascular surgeon. I do not operate on carotid arteries anymore. They came out when I was a fellow, and I'm like, oh my gosh, I gotta find something else to do. But luckily, 2 miles from here in San Jose, a very brilliant company many years ago created a little tiny catheter that allows me to do something I did in the operating room for 2.5 hours with a 2-week recovery and a lot of pain and discomfort in an 8-minute procedure in my office for 1/10 the cost. And those patients have the relief of their pain, their restless leg, and they get their wounds healed, and they're back to work that afternoon. So that is where technology is taking us, and it's remarkable. So where is the patient taking us? We know this. They're going to the computer. They're going to convenient care. They're going to urgent care. We need to pay attention to this. This is where they're going. And we need to have a healthcare system that accommodates that. And of course, 42%, I think it's higher now, go to the internet first for their healthcare. And the employers are tapped out. They're done. They don't want part of this anymore. Health savings accounts are on the rise. They don't want to hear, they want to be able to have their patients focus on on their own healthcare issues without having to invasion of their privacy. So why is medicine the only business when you pay cash, you pay triple? And what if we gave the patient the power to spend their own healthcare dollar? And here we are, UBERDOC. We are the very first patient-to-specialist direct pay platform. In 3 easy steps for the patient. We make it easy. You find specialists. We started with 6 core specialists. We have every medical specialist now. That includes internal medicine, primary care. We are doctors. We work for the patient. We're not providers. We don't work for the network. We have specialists all over the country now in 40 states. We have over 1,550 join every week because they want to offer price transparency. It is convenient. You just find that doctor who is local and nearby. Oh, what if they're out of network? Well, guess what? If your doctor who's local and nearby is not in your network, there's a problem, because you shouldn't have to travel 45 miles to get your care. And we offer it for a single transparent price of $300. So the doctor simply says yes, emoji, thumbs up, absolutely simple. There's no barrier at all on the doctor's side. You don't have to have a sequence of 15 numbers to get a patient approved. Direct access. In the current system, you twist your ankle, you go to walk-in, primary, x-rays, back and forth, and back. Here we go to the orthopedic, get treated, 1 visit, 1 answer, 1 price, totally transparent. We schedule, we bill, we collect, we send the email, HIPAA protected, HSA compatible, and all of our doctors are vetted. They have to be board certified and in active practice and with privileges at a local hospital. There are 8,000 walk-ins in this country. There's one across the street here. Now, yes, it's next to the Chipotle, and that's a good thing, but there are 800,000 specialists, and we have capacity in our offices. We have seats in our office because of no-shows. Why can't we bring some of those patients directly to the specialist for the same price point? And this is the very exciting thing, is what if we took all of these UBERDOCs? What if we gave them the technology to connect to their patients? A completely different model. We take a brick and mortar doctor like me, and Milton gives me the capacity to connect with my patients. What does that mean? That means that I can keep my staff at home. That means that I can do your post-op check remotely. It means that I don't have to maybe keep that overhead, or I can open more than 1 seat in my waiting room. This is an enormous thing, and all for a transparent transparent price because it isn't simply worth doing all the billing and the insurance. Keep it clean. So UBERDOC and VSee are creating we want to say we're giving our doctors superpowers, right? Superpowers, because we want them to take care of patients. We want them to focus on that. And this is a way, and we take the insurance out of the equation. That's the first step. The second step can be through insurance. It's the first step that's the most important part of this doctor-patient relationship, because everything else will follow easily. So we're fee for service. That may be a dirty word. Patient is in charge, more accountability, lowers the price, reduces the hidden costs, and every qualified doctor is welcome to join for free. So our network is basically limitless. Patient price transparency is required if you're going to restore this direct care market. I always say single payment, not single payer, but would be a nice thing. Let's not charge more, but charge less. Wow, that's kind of a weird business model, but you know it's going to work. Fee for service doesn't make sense in a personalized medicine world. One size doesn't fit all. We leave hierarchical models for public health initiatives. So if you think about it, are we really disrupting? And in this book, The Sharing Economy, he talks about hierarchical versus peer-to-peer relationships. We believe medicine is a peer-to-peer economic model. That's why hierarchical models have simply failed. So we like to say we're the new face of old-fashioned medicine, but honestly, you know, I want to end with just one slide here. This is I don't know if you recognize this. My father was born not too far from here. This is the island of Capri. This is Anna Capri at the top of Capri, off the coast of Italy. Axel Monte was an 1800s Swedish physician. I think he cured hysterical women. And he built this villa on the ruins of the Tiberius Villa. He incorporated the new and the old. And look at the vision we have. And that is my vision for healthcare in the future.
Perhaps any questions?
First of all, I love women entrepreneurs. We are geniuses and good, and so good luck to you. Yes. I'm wondering about the circle with the primary care physician. I know a lot of us are really concerned about the loss of the primary care ward as the coordinator of care. And of course, all the models that we are seeing here today really do discount the role of the primary care. How do you see that as you're looking at this model?
So this is a great question. We just kind of go with the flow, right? When we have a startup, we started with 6 core specialties, all surgical specialties, because I'm a surgeon, right? But we found out that the direct pay market is huge for primary care. There's so many of my colleagues who can't stay in practice, they become concierge. But concierge means that they have to leave out the Medicare population. They can't necessarily want to do that. They don't want to give up that panel. So we opened the platform, and our primary cares are coming to this platform to open a little cash lane that might keep the lights on for them. A couple of UBERDOC patients a week will pay their front end, so they can put their toe into the direct pay world, concierge world, without having to go all in, and also take care of their Medicare and Medicaid patients. So I think the answer to that is the primary cares have actually helped us with our platform. We're not trying to work around them. We're trying to empower them.
I appreciate what you're doing here is for a lot of physicians who are getting burned out in large systems, a lot of the answer to it's bringing autonomy back to physicians, which has been the #1 cause of burnout, at least from the AMA RAND study in 2012. So I love what you're doing here, almost from a way of empowering people to leave their institutions so they can actually have the faith of
or have change in their institutions. I mean, we do get letters all the time from doctors, help, I'm being held prisoner in a glue factory, right? I mean, my colleagues that are employed in big institutions are there for many reasons, but they want in.
Yep. I can say from being in here and having leave now, I see this as like great. I see so many people where I consult and set them up where they feel more confident knowing I can still have access to patients without my insurance contracts. One of the things that comes in here which becomes very complicated, I don't know if this is a rule that's known by many with Medicare, is if a Medicare patient signs up with you,
I got the answer
we
to
have
that.
to turn them no. Okay. Do you have them automatically
no, it's
turned
$50. So we strict with guidelines to Medicare guidelines of 2016. Yeah. So actually, the way UBERDOC works is $50 is the appointment hold, $250 when you're seen. If you're a Medicare patient, it's just the $50, and the doctor bills Medicare for the rest. So we are completely incompliant with the Medicare regulation. So for Medicare patients, it's kind of more of a pivots toward more to the an appointment hold concierge model, but we're finding it with when you navigate care for your elderly parents, which we all have, it's a really convenient model to do that. Pay $50 and make the appointment with the urologist when you can take them, and then you can be there with them.
Okay. Are you, as a provider or a physician out here, can you turn off the ability for Medicare patients to be able to schedule with you?
Oh, you can reject. The doctor has to accept the
Yeah.
appointment. The patient puts it in their own chief complaint. So if that's not your scope of practice, and you don't want that patient, you can simply say.
But do you
no.
have their
Yes, we
their age and their Medicare
the
status?
M pops up on the
Okay.
dashboard. No, it's we made it really simple, actually, at the level of a fourth grader for the doctors. We call ourselves anti-epic. Our real purpose here is democratizing access to care. I mean, I always hear the story, to get in to see my brother, who's a G1 oncologist at the Dana-Farber, you have to know somebody, call this, and it's like phone a friend. It's like UBERDOC is that friend. You don't need to do that. Anyone can have equal access to the best, and as long as all these doctors are participating, and right now no one says no, we're pretty much agnostic, we could really make it exciting to get patients access to the best with the push of a button and a transparent price.
How about the last question there, Becky?
I have a quick question clinically. I'm a physician as well. It infuriates the crap out of me to try and get through the hoops to get to who I need to see. I got a problem. I know what needs to be done, all that. So I get in to see this guy, though, and, the next element, a lot of your specialists are surgically related. You need an ACL repair, 10 grand, and now all of a sudden I've kind of circumvented my insurance step pathway, and now, we would pay for that, but you didn't get pre-approval for that, and go to your primary care doc, and blah, blah, blah. Now we're not going to pay for that. How does that
Well, so
get weeded out?
basically, your patient has to go through those steps before they get to you anyways. So that doesn't eliminate. But the patient's seen you now, and you've given them a plan. So then you can get the referrals, you can get the authorizations, which you'd have to do. But now your staff is working on getting those authorizations and referrals for someone you actually have to operate on, as opposed to a lot of times you do all that work for a patient either that doesn't show up or that doesn't need your services. So we basically really made it simple, and we haven't noticed any of these problems occurring. Plus, it's a transparency between the doctor and patient, so that the next equation, the next piece of it, is between them. The other thing is, so much of what we do is office-based. Office-based care is not network restricted. That's kind of a myth out there. People say it's network restricted, but it isn't. So a lot of our physicians can, in fact, solve the problem for their patients. And a lot of times you don't have to operate, right? A lot of times it doesn't end up with that. And the other thing is, human nature. If that patient paid cash to see you, you're unlikely going to order like the 3 tests that you wanted to order to make sure that you were at least going to make your overhead for that patient. It's just the way behavior is.
Great. Thank you so much. I think we got